Hello, my name is Dr. Minde, and we're winding up on our lecture series on cranial nerves. We are now on the 11th cranial nerve, which is accessory nerve. So it has a functional component which is visceral efferent of the cranial spinal cord. So the spinal accessory nucleus is in the ventral horn between C5. Give us the spinal caudal extension of nucleus ambiguous, the caudal extension of nucleus ambiguous by rootlets which are located. So the cranial accessory joins vagus, and from functionally it's called accessory vagus nerve. So what's the course and distribution? The accessory nerve exits the spinal cord laterally, dorsal to denticulate ligament, okay, and midway between the dorsal and the ventral roots. So it will exit the spinal cord laterally, dorsal to denticulate ligament, midway between the dorsal and ventral roots. Then it will now go upwards. From the spinal cord goes upwards, enters the cranium through foramen magnum. Then, after it has entered the cranium, it will curve downwards again to exit the skull through jugular foramen. Remember, glossopharyngeal was also exiting through jugular foramen and vagus. So 9, 10, 11 cranial nerves, they exit through jugular foramen. So remember, from spinal cord, enters the cranium upwards to the foramen magnum, then again we'll exit the cranium again through now jugular foramen. So the spinal and cranial accessory together join and exit through jugular foramen. So this 11th cranial nerve descends in the neck within the with the internal jugular vein and enters the medial surface of the sternocleidomastoid muscle. So on this surface, it gives branches to sternocleidomastoid, and after that, it will traverse the posterior cervical triangle, the posterior triangle of the neck, before now entering the lower portion of the trapezius muscle. Okay, so this is it. Okay, so you have the accessory nerve. This is the spinal portion from C1 to C, enters the cranium through foramen magnum here. Then it will be joined by the cranial root. Then together they will exit through the jugular foramen together with vagus. Okay, and then what happens? So you can see the cranial root, it appears like it's coming from vagus, and this is your cranial root, and then this is the spinal. So they live through that, and then it comes downwards like this from the jugular foramen, then supplies sternocleidomastoid, then crosses the posterior triangle of the neck to go and supply the trapezius. So what are the surface markings of this 11th cranial nerve in the posterior triangle? So there is 1/3 of the way down posterior border of sternocleidomastoid. So this is your posterior border of sternocleidomastoid. So as you go downwards, 1/3 of that distance to 1/3 way up anterior border of trapezius. So this is anterior border of trapezius. As you're going upwards, 1/3 of the way. So when you join the two, that's your landmark for surface landmark for spinal accessory. So as you draw downwards on posterior border of sternocleidomastoid, the first third, and as you draw upwards on anterior border of trapezius, the first third, then you join the two, that gives you surface landmark. What are the applications? Accessory nerve can be damaged due to poliomyelitis, okay, which is a viral infection affecting motor nerves. You can have spinal injuries because the spinal portion is from C1 to C5. You can have meningiomas, tumors of the meninges can compress it. Surgeries in the posterior triangle of the neck can affect the accessory nerve. So when you have unilateral damage, you damage one accessory nerve, the patient will have weakness in rotating the head down and away from the side of injury because of weakness of sternocleidomastoid muscle. So you cannot rotate the head down and away from the side of injury. So again, when you damage accessory nerve, especially the branch to trapezius, you get trapezius paresis. So there'll be drooping of the affected shoulder. Like when you tell the patient to shrug the shoulder or lift the shoulder upwards, you can see this one is drooping. So it's this sternocleidomastoid that has been affected. He's able to shrug this one, but this one remains drooping. Then there'll be reduced force when elevating the arm or the shoulder against pressure, and impaired shoulder abduction more than 90 degrees with scapular rotation. So like if you tell them to comb the hair, they'll be impaired abduction above 90 degrees. So this accessory or trapezius is not able to work, inability to shrug the shoulder and abduct more than 90. Okay. When we go to the last cranial nerve, the hypoglossal nerve, it's principally motor, so it contains general, somatic, efferent, innervating muscles of the tongue. So hypoglossal nucleus is the nucleus of this hypoglossal nerve. So it's a motor nucleus of hypoglossal nerve. It contains lower motor neuronal cell bodies, and it's usually located in the medulla, close to the midline. And remember the hypoglossal trigone as part of the structure in the floor of the fourth ventricle. That is where the motor nucleus of hypoglossal is located. So what's the course and distribution? It exits the brain stem between the inferior olive and the pyramids. Remember, from the brain, the medulla, you have the midline structure, followed by pyramids, then olive. So between pyramid and olive, that's where the hypoglossal nerve exits. Then from there, how does it exit the cranium? Through the hypoglossal canal. Then in the neck, it will descend to the level of the hyoid bone. Then what happens to hypoglossal nerve? It will now curve forwards between stylohyoid and hyoglossus muscles. Okay, then it lies on the hyoglossus muscle. So when it enters the tongue, it innervates hyoglossus, genioglossus, styloglossus, and intrinsic muscles. So it innervates all tongue muscles except palatoglossus. So hypoglossal nerve innervates all the tongue muscles except palatoglossus. Okay, so hyoglossus, genioglossus, styloglossus, these are extrinsic muscles and intrinsic muscles, except palatoglossus, which is innervated by the pharyngeal plexus. So we have nerve fibers from C1 spinal nerve that usually join the hypoglossal nerve for a short distance as it descends in the neck. Before the nerve enters the tongue, these fibers leave the hypoglossal nerve and form two branches. So there will be a nerve to geniohyoid and thyrohyoid muscle and superior root of ansa cervicalis to infrahyoid muscles. So before hypoglossal nerve enters the tongue, we have fibers, these C1 fibers that had joined it. They leave and now form two branches. Remember, we said C1 fibers from C1 portion of the spinal cord usually join hypoglossal nerve. But before hypoglossal now enters the tongue, these C1 fibers will leave and form two branches, nerve to geniohyoid and thyrohyoid, and a superior root of ansa cervicalis, which innervates the infrahyoid muscle. Then we also have postganglionic sympathetic fibers from sympathetic cervical ganglia that also join this hypoglossal nerve so that they're able to distribute the tongue vessels and the glands of the oral mucosa. So this is your hypoglossal nerve exiting through your hypoglossal canal. You can see it there, but usually C1 fiber joins it. Then before it gets to the tongue, the C1 fiber now leaves. Okay, you can see it is going to give nerve to thyrohyoid and nerve to geniohyoid, but hypoglossal nerve continues. So this is what we call ansa cervicalis. Okay, you can see this loop. This C1 coming downwards, it forms loop, superior root of ansa cervicalis. It follows hypoglossal, so that's why we call it descendants hypoglossy, and this is your ansa cervicalis. So it innervates the strap muscles. Again, C1 follows hypoglossal nerve, but before hypoglossal nerve enters the tongue muscles, C1 leaves it and divides into nerve to geniohyoid and nerve to thyrohyoid, and it also forms an upper root of the ansa cervicalis that will innervate the strap muscles, inferior belly of omohyoid, sternohyoid, sternothyroid, and superior belly of omohyoid. So ansa cervicalis is formed by C1, C2, C3, but C1 hitchhikes on hypoglossal. So what are the clinical disorders of hypoglossal nerve? When you damage hypoglossal nerve, the damage can be caused by vascular lesions of the brainstem, polio, tumors within the cerebellum, tumors of the brainstem, surgeries of the tongue and the mandibular region, surgeries of the carotid artery in the neck. So all these can damage the hypoglossal nerve. So where the nerve, you need to know the cause of the nerve, then you can easily figure out the site of injury. So in upper motor, remember upper motor is from cerebral cortex to the nucleus of the nerve. Upper motor lesion of hypoglossal will cause contralateral paralysis, okay? Because descending corticobulbar fibers cross. So unlike facial, hypoglossal nucleus gets upper motor control from contralateral cortex. Facial was getting upper motor control from both cortices on the upper part of the face and contralateral cortex on the lower part of the face. but hypoglossal is getting upper motor control from contralateral cortex. Now, in unilateral lower motor lesion, the tongue will deviate towards side of lesion. In facial nerve palsy, the face was deviating to the normal side, but in hypoglossal palsy, the tongue is deviating to the side of lesion. Okay, so like this side, there's a problem. This is normal. So you can see it has deviated to the side of lesion. When you ask the patient to protrude the tongue, you see the tongue is deviating towards the side of lesion. This part, there is atrophy. So in lower motor neuron. So hypoglossal paralysis and examination. We've said hypoglossal nucleus at the brainstem. It will get upper motor control from opposite cerebral cortex. So this one will supply the nucleus on the opposite side. So when there is lesion at this area, it's the opposite side of the tongue that will be affected. And we've said the tongue deviates towards the abnormal side. So the tongue deviates opposite to the lesion. Okay, so look here. Here is the site of lesion, upper motor lesion. And this side is controlling this nucleus of hypoglossal that is affecting this side of the tongue. So in upper motor lesion, if you injure here, you're going to affect this side of the tongue. So the tongue will deviate opposite the side of lesion. So the lesion is on this side, but the effect is on this side. So you deviate towards the abnormal side. Now, in lower motor neuron paralysis, lower motor is from the nucleus to the tongue here. So lower motor neuron paralysis at this level, okay, from the nucleus to the tongue. This is the lower motor neuron. So you're going to affect this side. So the tongue will deviate to the side of lesion. The lesion is on this side and the problem is on this. So you deviate towards the abnormal, which is the side of lesion. I hope this is clear. Upper motor neuron, this is controlling the opposite side. So the tongue will deviate towards this side, the opposite side of lesion. But in lower motor, this is the side of lesion. So this is the place where the paralysis will occur. So deviation of the tongue will occur towards the side of lesion. Okay. So you ask the patient, you inspect and you check for mobility of the tongue. So in upper motor lesion, so if there is lesion here, you will affect this side. So there will be deviation on this side. So deviation will occur opposite to the side of lesion. If there is lesion here on the left, you affect the right side and deviation will occur towards the right. But if there's lower motor lesion is from the brainstem to the tongue itself, so hypoglossal nerve itself. So if there's lower motor neuron lesion here, there will be still deviation but towards the side of lesion. Thank you very much. So we've completed our series on cranial nerves. It was very long, so you need to go through these videos over and over again for them to make sense. So you need to know for each cranial nerve what are the nuclei of origin, where the nuclei are located and the functions of the nuclei. Then you need to know the location of these cranial nerves at the brainstem. You need to know how do they exit the cranium, through which foramina, what is the intracranial course, what is the extracranial course, and what are the branches and distribution of the nerves and the applied aspects. So you need to understand the cause so that you know causes and sites of injury, and then you need to explain what are the clinical symptoms and the anatomical basis. So you need to say there will be double vision because of this and this and that. The tongue will deviate to the normal side because to the abnormal side because of this and that. The face will deviate to the normal side because of this. So you need to always mention the anatomical basis of each symptom. You just can't mention a symptom without explaining what is the anatomy behind it. Okay, like the upper part of the face is paired because it receives upper motor control from both cortices. So that's the anatomical basis in upper motor neuron lesion. So you must explain a symptom and the anatomical basis. Thank you very much.